Hi, everybody. Welcome in. We're going to give it just a couple more minutes for folks to join, and then we will get started. Well, wonderful. Maybe just a few reminders before we kick off the session. One, this webinar is being recorded, and we'll be sharing out the recording along with materials right after. For anyone who needs it, closed captioning is available. You can select the CC or transcript icon from your toolbar to turn on subtitles. And if you have any other accessibility needs for this or future sessions, please feel free to reach out to me directly. My email I will put into the chat. Let's see, make sure it goes to everybody. There it is. Fantastic. I'm hopeful that we can keep this a very engaging session. And so with that, I'd like to highlight that the chat is open to everybody. We do ask that you remain respectful in your engagement, but certainly encourage comments and questions and exchanges throughout today's session. For questions for panelists, if you could utilize the Q&A feature that's located on your toolbar. There's no need to wait. You can add your questions at any time, and we'll circle back at the end of the session for Q&A. Okay, let's move on. I am so honored to welcome Margaret Doyle from the Office of Assemblymember Boroner, this Assembly District 77. Margaret is joining us to set the table with some introductory remarks on behalf of the member.
Thank you so much, Maria. I'm so excited to be here, y'all. I represent Assemblymember Tasha Berner. Our district goes from Carlsbad down to Coronado in San Diego County. It's a wonderful district all along the beach. So I just wanted to welcome you all here today on behalf of the member to talk about some of the crucial questions, one of the really most crucial questions that we all are faced with at some point in our lives, which is how to afford care for our aging friends and family members. As the cost of living rises, we in California are struggling to meet the needs of middle and low income seniors in California, including providing accessible housing alternatives, increasing disability access, and ensuring connections to medications and long-term care. So I'm really inspired by the work here, people like the California Collaborative for Long-Term Services and Supports and all of your team members. We have great opportunities to learn about how to come together and provide care for our aging population. And then I did just want to touch very briefly on a couple of the bills that Assemblymember Berner is running. This is an issue that's near and dear to her heart. We have two bills this session aimed at benefiting our senior and aging population, AB 265, which aims to secure permanent funding for the Senior Citizens and Disabled Citizens Property Tax Postponement Program, which would authorize the State Controller's Office to directly pay county property taxes owed by a claimant who is a senior, blind, or disabled. And this really prevents a lot of our seniors from falling into homelessness. And then AB 559, which would allow the personal income tax return form to include a space for the California Senior Legislature Advocacy Voluntary Tax Contribution Fund. So when you check that little box on your tax return, you have the option to donate a little bit of money to the California Senior Legislature, which is a group of representatives who advocate for legislative priorities that will benefit California's aging population. That's really all I had to say. I'm so excited to be here, and I'm just going to turn it back over to Maria to get us started. So thank y'all for having us.
Thanks so much, Margaret. Such a pleasure to have you. And I know you're going to be hanging out with us for the rest of the session as well. So feel free to ask questions or anything that comes up. We're here to just have a conversation. So before we get started, I just wanted to provide a really high level overview of California's LTSS affordability challenges. So why this discussion and why now? And again, very high level, and then I will turn it off to Dustin to get into the weeds with you all for our policy wonk groups. So why this discussion and why now? There are several factors driving the conversation around affordability of care. And the most prominent one is that California is going through a transformative demographic shift. And I think we go to the next slide, Nancy. Thank you so much. The number of adults age 60 plus in California is growing, and in the next few decades, that growth will outpace that of working age adults and children. You can see here on this graph, based on data from the Department of Finance, that currently older adults make about 22% of the state's population. That's in 2023. And that'll grow to about 25%, or 1 in 4 Californians, by 2030, and continue on that trajectory through 2060, where we anticipate that 33% of California's population will be 60 or older. And in addition to a growing number of older adults, we also know that disability prevalence increases with age. California is currently home to nearly 7 million disabled adults. That's about 1 in 4 Californians that have a disability. And while disability can absolutely occur at any age, the demographic shift is anticipated to drive a 160% increase in the number of disabled older adults. And with that, the demand for support is also increasing. More than half of California's older and disabled adults report needing help with routine care, such as housekeeping, care coordination, medication management, meals, transportation, etc. And 1 in 5 report needing help with personal care, such as bathing or toileting. And while we've traditionally over-relied on caregivers, and let me just check the slides. I think we're on the next one, Nancy, and you could probably stay on that one for just a bit. Thank you. And while we've traditionally over-relied on caregivers, for example, adult children who can come in and provide support, we're finding that more and more older adults are living alone without family. That's on the next slide. Without family members nearby to be able to run over and help with this or that. And I also think that as a society, we're becoming more aware of the impact of caregiving. There are roughly 4.7 unpaid caregivers in California, the majority of which are women, particularly women of color, who are often in this position of juggling jobs and raising children and caregiving. They're spending upwards of $13,000 annually in out-of-pocket expenses, and contributing a collective 4 billion hours of unpaid care to the state. And they're burning out as they're doing that. At the same time, alternatives are out of reach for many Californians. So on the next slide, you'll see a demonstration. Simply put, LTSS is expensive. For adult daycare, that'll average about $20,000 for 5 days per week. This is on an annual basis. For home health aides, averages just over $43,000 for 30 hours a week. Assisted living can easily run $54,000 annually on average. And nursing home care, again, on average, can reach upwards of $127,000 annually. Rates are higher in higher cost areas, such as the Bay Area. And I, as I was putting this together, I was trying to get a feel and ground myself in what do these expenses really look like. My husband and I spend $2,000 a month on our mortgage. We spend $24,000 annually on our home. So this is just to give you a comparison of where, how these costs are stacking up. LTSS is largely paid for by states. In 2020, US national spending on LTSS totaled $400 billion, 43% of which was Medicaid spending. California is unique in many ways, and one of them is that we call our Medicaid program Medi-Cal. So Medicare also contributes, but only covers very limited LTSS. And so national Medicare expenditures in 2020 hovered right around 18%. For those who qualify for Medicaid or Medi-Cal in California, they're able to access LTSS through a safety net. But for those with annual incomes just above that threshold on the next slide, which is about $20,120 per year, these supports are largely out of reach. There are about on the next slide, there are about 1 million older adults in California who are at risk of spending down and becoming Medi-Cal eligible, but many more who are not likely to qualify. Those individuals hovering right around 401 and 650% of the federal poverty level, with incomes of up to $94,770 annually. 89% of folks in that bracket would not be able to afford private assisted living without selling their homes, without using that equity. And so here's the policy challenge. What can we do to support our middle income older and disabled adults to prevent them from falling through the cracks, to ensure that they have access to the care they need, that they can live with dignity and independence in the setting of their choice? And what will happen if we do nothing? What will be the outcome? I think from experience, we can all agree that the outcome will be more individuals who are unnecessarily institutionalized, placed in high-cost institutional settings, largely paid for by state dollars. And at this point, I think I'd love to turn it over to Dustin. Dustin Plotkin is the principal and actuarial consultant for Oliver Wyman.
Oh, thank you, Maria. Can everyone hear me okay?
Yeah,
Excellent.
absolutely.
Okay, well.
And I know you've got some screen sharing, so I'll give you a minute to pull that up.
Yes, yeah, excellent. I'll pull that up in just a moment. Just want to give a bit of an introduction and introduce myself, and then I've got some content to share with everybody. But I appreciate being invited to present on the fruits of our labor with Assembly Bill 567 and the feasibility work associated with it. Today, I'll be providing an overview of where things are at with AB 567, covering both the feasibility component as well as some of the actuarial analysis. That actuarial work remains ongoing, so I'll cover just very high level, mostly focusing on the feasibility study. It's been about a 2-year journey thus far, and we're in our final stretch with our work and wrapping up towards the end of this year. So I've got about maybe 25 minutes of content. I know, Maria, you mentioned we'll have some times for questions, so happy to answer any questions at the end. But as introduced, my name is Dustin. I'm an actuary. I'm a consultant with a company called Oliver Wyman, and I specialize in long-term care insurance. My colleagues and I were retained by the California Department of Insurance to support them with AB 567. And in particular, our roles are twofold. Firstly, we were asked to facilitate discussions among the task force, and I'll get into the task force in a little bit, but really to facilitate discussions with the AB 567 task force, and ultimately put together a feasibility report summarizing the task force's recommendations. And the second part of our scope is to perform an actuarial analysis to quantify the estimated cost and long-term viability of the various task force recommendations. And just to be super clear, the content that I'm going to be sharing with everyone from our feasibility report, those reflect the views of the collective task force. They're not necessarily my views. As I mentioned, I'm the facilitator. So with that said, let me pull up the presentation, if you bear with me for one moment. All right. That should be it. I'll make it full screen. All right, can I get a thumbs up if everyone can see it? We're good? Okay, excellent. So that's me. I already spoke about myself. So let's talk what we're going to talk about today. So I'll provide a little bit of background on the Assembly Bill. I'll share an update on where we are at in our timeline. I'll highlight some of the program design recommendations from our task force, and then cover a little bit on next steps as we go forward from here. So a bit of background on the Assembly Bill. So AB 567 was enacted in 2019, and essentially that bill established a task force within the insurance department to explore the feasibility of implementing a statewide long-term care insurance program. That task force is comprised of 15 members, primarily volunteers, but also representation from various government agencies with wide facets of expertise spanning, there's a health policy expert, there's representation from long-term care providers, family caregivers, health professionals, a senior / consumer organization. There's an actuary on the task force. There's representation from the private long-term care insurance industry, as well as long-term care worker organizations. And we have also received technical expertise from several California government agencies, including the Department of Aging, the Department of Healthcare Services, and of course, the Insurance Department. And so in terms of the task force mandate, ultimately, it's, as I mentioned before, the exploration of a culturally competent statewide long-term care insurance program within the state of California. And that's ultimately their mandate, but a key element of that mandate is, okay, well, how can a potentially new program fit within the existing landscape, LTSS landscape in California, which is rather complicated, considering both existing public programs, Medicaid or Medi-Cal, for example, as well as interaction with those who have private long-term care insurance either today or in the future. And so a lot of the discussion was around, okay, if we were to, or if the state were to establish a new program, how would it interact? How would it coordinate with what is there today? Moving on to timeline, the task force first convened in 2021, so about 2 years ago. And we've gone through about 20 or so publicly held task force meetings where we discussed a broad range of topics that you ought to consider in the design of a statewide long-term care insurance program. And that effort culminated at the end of last year in December, where the task force unanimously approved the feasibility report, which, as I mentioned, summarizes the recommendations from the task force. In particular, the feasibility report includes 5 program design recommendations, and I'll go through those in greater detail on the coming pages. So that's in the past. Where we are today, right now, my team and I, we are focusing our activities on the actuarial analysis, so essentially quantifying the estimated cost for each of the 5 designs, as well as the long-term viability of such a program. And so that's in flight right now. We are anticipating to provide some preliminary estimates this summer in July. And then in September, we anticipate providing a draft version of our actuarial report. Similar to with the feasibility report, lots of questions, lots of interaction that then informs some revisions, and ultimately finalize the actuarial report by the end of this year. After which that report, the actuarial report, will be submitted to the California Legislative Assembly, the governor, the insurance commissioner. And at that point, really the scope of this bill would have wrapped up, and things would be in the hands of the legislative body to really drive where things go from there. Potentially, that could be a draft bill. It could be further analysis. That's really, outside of my purview, but that's where things would move to next at the end of this year. So that's timeline. I'll step forward. So I have a couple pages that summarize the recommendations from the task force. 3 pages on that. So this one, page 7 on my screen right now, is that like 10,000-foot view summary of the 5 program designs that the task force recommended, ranging from lower cost, number 1, to highest cost, number 5. And you might be wondering, well, why 5 programs? It's not intended to be, let's go with all 5 and individuals can pick and choose which one they prefer. Rather, the intent is provide the legislative assembly with options, recognizing that there's going to be a vastly different cost for each of these designs, provide the legislative assembly with these different packages to consider along with the anticipated price tag of each, recognizing that the legislative assembly would have good perspective on what might be financially feasible to move forward with, and based on that, consider which of these options might align with that view. So anyway, about the 5 designs. So I mentioned, number 1 is on the lower end of the spectrum. We've labeled that as a supportive type of program, supportive long-term care benefits program. So that design would not include some of the more comprehensive or more costly types of services. In other words, care in a nursing home, in a residential care facility, or home health aid would not be included in design number 1. Rather, it would include some of the less costly or supportive type of services, including adult daycare, caregiver support, meal delivery, transportation, and minor home modifications. And that design at number 1 would include $36,000 in lifetime benefits. Moving to the complete opposite end of the spectrum, number 5 is the most comprehensive design that the task force recommended. That one includes a much broader set of services, including nursing home, residential care facility, home health aid. It includes financial support for family or informal caregivers, so much broader set of coverage. In addition, the lifetime benefit for that design is about 4 times higher, $144,000. And then designs 2, 3, and 4 fall somewhere in between. So those are really the two goalposts, if you will, and there's a few other packages in between that were recommended by the task force. Moving forward, I'll talk a little bit about the common or notable common features associated with the designs. And I've got 2 pages on that. This first page covers some of the design features that got the most attention, or a lot of discussion went around, very thoughtful discussions. And then on the next page, we list out a handful of other common design elements. I won't go into this one into too much detail due to time constraints, so I'll focus more so on the 3 key ones on the page I have in front of me right now. So that's benefit portability, financing, so how is this program potentially going to be financed, and then finally interaction with the private insurance market. So move it to the left side of the page on benefit portability. The task force and the members of the public who participated in our task force meetings felt that it was very important to include portability provision. And so when I say that, I mean, if someone contributes to the program in the state of California, and at some point they move out of state, whether it's elsewhere in the United States or somewhere internationally, the task force had a strong view that those individuals should be able to use their benefits. And so all 5 program design recommendations include some degree of portability. Now, the amount of portability that you offer can have a pretty substantial impact on the cost. So it's a bit of a trade-off. How flexible do you want to be with the portability? And so depending on the options, that portability may be limited to the United States only, not covered internationally, or it may reduce the amount of benefits you could receive by cutting it in half if you were to use the program outside of the state. So there's some variability among the 5 designs. That said, all 5 of them, it was very important to the task force to include some degree of this portability. Next one on this list is program financing. So how is this program, or how could this program be financed? And so we brought in a tax policy expert to walk the task force through really all options under the sun on how a public program of this nature could potentially be financed. And ultimately, the task force recommended a program that is primarily financed via a payroll tax. And I'll share a bit of details on that. So firstly, the task force felt that it was important to make sure that that tax is a progressive structure. In other words, tax rate increases as an individual's income increases. That's number 1. Number 2, the task force recommended that the tax be split among both employees and employers. In addition, the task force recommended to maximize the number of individuals who can be covered by the program, require the self-employed population to participate in the program as well. They would contribute based on a tax rate as a function of income tax rather than payroll tax for obvious reasons. And then a couple other nuances that got a lot of discussion is, when we think of the lower income population, when we think of affordability of a tax like this, the task force felt that it was appropriate to waive the contributions for lower income individuals. So there's a bit of an exception for design 2. I won't go into that, but holistically, the task force recommended that individuals below a certain poverty threshold be covered by the program, but receive a waiver from having to contribute towards the program. So that introduces another element of progressivity. On the other end of the spectrum, the task force felt that it was necessary to introduce a maximum in terms of what someone could contribute to the program in a given year to ensure that the benefits that someone could potentially receive were reasonable in comparison to what they contribute to the program. So a cap at the top, a waiver at the bottom, and progressiveness in the middle. And one final thing on financing that I want to mention is, and this got a lot of attention as well, is based on the nature of the design, a payroll tax, that could potentially leave a large portion of individuals today that could not be covered by the program. That's particularly the individuals who are currently retired. So no payroll, no contributions, no program. And so this came up several times from the task force, from the public, to asked us to examine what it would cost to potentially extend coverage to the population that is retired today. And so the actuarial work that we're doing will include an analysis of exactly that. On the right-hand side of the page, one final thing I want to talk about is interaction. That's, as I mentioned at the start, a crucial element of when you're thinking of implementing a new program is how is it going to interact with everything else that offers similar types of services, and that can get very complicated. And thinking about private insurance, or those who have long-term care insurance, that the task force felt that for those who've already own private long-term care insurance today and have potentially have been contributing towards that for 10, 15, 20 or more years, to give them the option of opting out of the program. The requirement would be that they would have to have that coverage in place before the program becomes effective. In addition, there's a second tier to the recommendation, and there was recognition that regardless of the design, and I'll flip back, regardless of whether it's design 1, 2, 3, or 4, or 5, in all likelihood, there will be a need for care, or there may still or will likely still be a gap in financing for care beyond any of these potential program designs. And so the task force felt that it was important to incentivize individuals to continue to purchase private long-term care insurance if they can. And so to provide that level of incentivization, the task force recommended that for individuals who purchase private insurance in the future, they can be eligible to a partial discount or a reduction in their contribution amount. And that would be financed on the basis, and I don't want to get into too much detail, but basically the private insurance would pay first and therefore reduce the likelihood and the amount that an individual might use the state program for. So the discount would naturally be funded by the less likelihood that they would tap into the state benefits. So hopefully that was informative. I'm going to move on to the next page, and there's a lot of information here providing a bit more background on the recommendations from the task force. I'll just maybe hit on the first one, the structure. And so we talked a little bit about the benefits, but one thing I want to cover is the contributions. And so the task force recommended that there be a minimum number of years that an individual must contribute towards the program before they become eligible to potentially receive benefits. And so depending on the design, that could be 5 years or it could be 10 years. And there was also recognition that if someone cannot vest for the full 5 or 10, potentially someone who's getting close to retirement, to offer them a partial or pro rata benefits. Yeah, I think that's all. I'll wrap up this page with that. And I've just got one final page and then I'll turn things back to Maria, talking a little bit about next steps. And so in addition to completing the calculation of the costs for the 5 designs, the 5 task force recommended designs, the task force asked that we look at several alternative scenarios. So there's like the 5 main designs, but if we change A to B or C to D, what would that look like? And so we're also looking at a handful of sub scenarios for the 5 designs. And based on the outcome of that costing, it's potential, or there's potential that the task force may amend their recommendations on the 5 designs in advance of the end of the year when our actuarial report would be submitted. And so that would be documented in the report. Another thing I want to call out is, one thing that this was raised several times by the public and the task force. It's great that there might be this potential program, and there's a lot of talk about how how an individual could qualify and who would be covered. But equally important is to understand who might not be covered by the program. And so, in addition, we will be looking at estimating the amount of individuals in California who would not be eligible for benefits and the types of groups that would make up those individuals. And looking at the bottom right, I talked about that already, the potential financing for current retirees. And then on the bottom left, in recognition that there's still some things to unpack in terms of, for example, defining how a little bit more on how the interaction with private insurance and the program would work, or coming up with a roadmap on program communication outreach, as there's some topics that we couldn't fully hash out with task force through the task force meetings. And so the task force recommended a handful of separate working groups to examine a handful of topics, and all of those are defined within the feasibility report. And there's a link to that at the very bottom. You can also find the report on the California's Insurance Department's website. With that, I'll pause here. Hand things back to you, Maria.
Well, thanks so much, Dustin. And I'm really glad you're hanging around until the Q&A, because we do have a lot of questions, a lot of interaction coming in the chat and the Q&A that I'm archiving for our session later. But for now, I actually want to turn it over to my colleague, Emma Strauss with Unlock. She is the public policy manager, and she will actually moderate this panel discussion for us and help us with Q&A today. So Emma, I'm going to add a little spotlight to you, and then I'm going to fade off into the background and let you take over.
Perfect. Well, thank you so much, Maria, and thank you, Dustin, for the presentation. Maria, I really appreciate you starting us off today with setting the stage about why this discussion and why now. And I think from the way that you framed the affordability challenges, particularly for middle-income Californians, it's very clear that our current approach to long-term care financing isn't working for individuals who need these services, for their families, for their caregivers or other providers, and for payers. So this is a very important and timely conversation to be having. What are the parameters of a program that will provide Californians of all incomes and abilities with access to the care that they need to live with dignity and independence in the setting of their choice? So I think, as we just heard from Dustin and understand from the deliberations of the task force that led up to the recommendations in the feasibility report, there are a lot of trade-offs to grapple with in considering the affordability, accessibility, comprehensiveness. And we have a fantastic panel here to share their reactions and dig into these questions and talk about what comes next. So I will introduce the panel members now. Maria, if you are going to spotlight them to bring them up onto our screens. We have Ramon Casablanc representing the California Alliance for Retired Americans. Malcolm Harris, the Associate Director of State Campaigns at Caring Across Generations. Dan Ockenfuss, Public Policy Manager at California Foundation for Independent Living Centers. Sarah Steenhausen, Deputy Director for the Division of Policy, Research, and Equity at the California Department of Aging.
And Emma, Sarah's caught in a meeting. She'll be joining us shortly. So I will put her on stage when she arrives.
Fantastic. Thanks, Maria. And then Nina Weiler-Harwell, the Associate Director of Advocacy and Community Engagement for AARP California. So thank you all for being here and being part of this conversation. So I'd like to start with maybe some initial reflections from our panelists about things that they are excited about or that they think might be missing from the feasibility study and the task force recommendations that Dustin just walked through with us. So I'll pose a few questions to specific panelists, but welcome others to jump in with their thoughts, and welcome the audience to continue submitting their questions via the Q&A icon as we're talking in preparation for the Q&A session at the end. So Nina, maybe let's start with you. I know that AARP has put out some great resources about the cost of care. So maybe you could tell us a little bit about that and how you see these program options actually impacting the affordability challenges and what will make a meaningful difference to people who have long-term care needs.
Sure. So good morning and we're in the afternoon. Good afternoon, everybody. Thank you for having me here today. I'm really happy to talk about that. So AARP has been engaged with this work. We're coming on 6 years now. And really, AARP, along with our partners, came to the conclusion that something needed to be done beyond what we were already doing to assist especially, say, lower middle income, even upper middle income individuals in covering or at least deferring or covering some of the costs of long-term supports and services. Earlier on, Maria did cite some of our research, but I do want to repeat in case you missed it. This is according to the ARP and SCAN LTSS scorecard from 2020, with a new one coming out later this year. The annual median income of a 65 plus couple is $54,000. That is the cost of assisted living in California. The cost for a nursing home facility, if you don't qualify for anything, Medicare, remember, only gives you so much coverage before you have to opt. You either have to go into Medicaid or you have to private pay. That's $127,000. We know that people are struggling. Very few people have long-term care insurance. 4.2% over the age of 40 have purchased it. Something needed to be done. Most of our members, the people I speak to, do not qualify for Medi-Cal. They are above the income limit for that, even with the asset limit going away. I believe it's next year. And we were really looking for solutions such as a social insurance program. So, you know, this is going to be, there's going to be a pretty long road to get this going because it's a complicated issue. Dustin's already kind of laid out all the complexities of even looking at 5 potential plans and the different kind of variations within each plan. But I'll just say that our folks are struggling. Family caregivers are the ones carrying the burden. They spend over $7,200 a year on average caring for an adult loved one with a disability. So if you're talking about a median income of $54,000, or if it's still a working person, ARP does represent people 50 and over, it's still a sizable chunk of your income. And that means you're not saving for retirement. You may be, you know, having to forego some of your home equity to cover this. It's just, the current numbers do not add up. So this is why ARP has been so thoroughly engaged in this. I do want to say that as our state president, Joe Garbanzos, had the privilege of sitting on the task force, and we do appreciate the robust stakeholder input that was taken. We gave you a lot of feedback and pushback, and that happened. So we are where we are now. Dustin, I had a question in chat that I hope you can answer. And it had to do with the 20-year scale up in benefits. And I'm not clear how that would really promote intergenerational equity if somebody, say, works in a difficult occupation, has a disabling event at, say, 35, 40, which can happen, they don't get their full benefits. And that could be very concerning, especially, so again, because ARP, we're not just talking about ARP members, we're talking about their loved ones that they're caring for. So if you could speak to a bit to that. And I assume, second part of the question is, there'll be toggles in the report to measure cost without that 20-year scale up, right? Just with the 10-year vesting. I know we have scale up till 10, sort of, but if you could talk about that, I'd appreciate it.
Yeah, so one key thing to keep in, so when we talk about the intergenerational grade up, that's in relation to the years since the program launches. It's not a function of an individual's age. So basically, let's assume 5-year vesting. If someone contributes on day 1, they contribute for 5 years, and then they have an incident where they would need a claim in year 6. Because it's so early to the program launch, the available benefits in year 6 would be lower than what would be available in year 20. And so I'm going to use hypothetical dates. So let's say the program completely hypothetically comes into effect in 2025. In that case, full benefits for anyone that qualifies would be available 20 years later, 2045, and it would grade up every year until then.
And then will there be something in the report that examines the cost without that grade up?
I'd have to double check. I don't recall offhand, but I will look into that, Nina.
Yeah, that would, I would request that be in there. Or even like a 10-year grade up or something, like different iterations, just so we can see the full breadth of costs. Thanks.
Yeah,
Thanks
yeah,
for
not a problem.
raising that question, Nina. So maybe sort of on that question of intergenerational equity and thinking about how the program works at the beginning for Californians who are already retired, who are no longer making payroll tax contributions, and might be excluded from a payroll tax finance program. You know, Ramon, maybe you could talk a little bit, would like to hear your thoughts on how the current recommendations account for the Californians who are already retired and what more we need to be thinking about for that population.
Well, as I see the system, it doesn't have basically anything in it for people who are already retired. By 2025, which is the year Dustin thought, you know, maybe that's when we start, everybody who's a baby boomer will already be 64 or older. Most of us will be in our 70s and 80s. So we won't be working, we won't be making payroll contributions, and we will not be accumulating any kind of credit in the system. So for the vast majority of baby boomers, basically a payroll only funded system doesn't do anything. Maybe it helps our children, which is nice, but on the other hand, you know, for us old folks now, there's nothing there. I think you might want to look at something like the Social Security Act of 1935, because what they did there was Title I and Title II, and most of us think of Title II as Social Security. That's the system where you pay in and then you get money back because you paid in. That's where we all are now. That's Title II. But there was a Title I back in 1935. They knew there were already old people in 1935, and they needed to do something for them. So basically, they did a general fund pull to have some kind of a benefit for folks that at that time were over the age of 65. So I would think that we need a progressive tax base that goes outside of the payroll tax to do anything at all for people who are currently baby boomers.
Malcolm, I'm wondering if that's something that you would like to chime in on as well. I know that we've talked a lot about this progressive payroll tax as the primary funding mechanism, but on this question of if there are other financing approaches that should be part of the conversation.
Well, I think taking into consideration all possibilities should absolutely be a part of the conversation, and what that could look like, and especially when we talk about a state and a world economy as wealthy as California. I think it'd be behoove us to look at all options available and then make sure that we have thought about them as deeply as possible. So much appreciation for a lot of the work that the California Aging and Disability Alliance has been doing around making sure, and the LTSS for All Grassroots Coalition has been doing to lift up that issue. So whether it's a hybrid model that takes into consideration either a corporate or some sort of wealth tax, or some sort of other options, really thinking about those deeply and looking at other models. So like WaCares in Washington State, the Kapuna model in Hawaii, but looking at that and making sure that all of those are taken into consideration. Absolutely. I do want to point out one fact, though, just thinking about this and the potential impact in a state as wealthy, but also as expensive as California. And so I appreciate the fact that we are thinking about low wage and middle wage earners. But one piece that I wanted to add to the great overview that Maria did in the beginning is that the Department of Aging's release of their California Master Plan for Aging, page 7 lifts up the high number of folks who are family caregivers, unpaid caregivers, who are aging into poverty. And those numbers are just taking into consideration that 45% of those are Black women. And so also thinking about how that happens, and so also the systemic pieces of that. And so as we're thinking about the models, also the impacts on communities across California through a variety of lenses, I think is important for us to be thinking about. So apologies for running off at the mouth, but wanted to make sure that I had a chance to respond to your question.
No, I appreciate that, Malcolm. I appreciate you bringing in this question about workforce and about caregivers. I think, we're all aware of the important role of informal and friends and family caregivers in particular when we're talking about long-term care. And I know that the task force recommended that the program, reimburses family caregivers who meet some sort of certification or minimum training requirements, but acknowledge that further research and work would be necessary to think about what kind of model their family caregiver reimbursement would take. So let me open that up to the group. Are there things that we should be thinking about recognizing caregivers and making sure that a program like this is also supporting the workforce that we need to make these services available?
Well, I can go if you don't mind. What I raised in front of the task force a year or so ago is the cash and counseling model, which has been tested in a number of states, has been found to be successful. Basically, that recognizes the fact that two-thirds of people who get long-term care get it entirely from unpaid caregivers. That is family members and friends. That's where most of the long-term care system is. So if we only have money that goes to the paid side of the system, we're missing two-thirds of the people who are getting long-term care. So the cash and counseling model was an approach that, because it's not that unpaid caregivers want to get paid, it's that they have a lot of expenses that they need to cover. And that's what the cash is for all of those expenses that come up in the course of providing the care. And then the counseling, ties together the cash reimbursements with some form of responsibility. What is this money exactly for and how much do you need? But also it then provides a way to help train caregivers in doing a better job, because without any kind of training at all, unpaid caregivers can make serious mistakes, which then snowball into paid caregiving situations. So cash and counseling has been around for 20 years, has been proven to be effective. And I think that's one way to go in terms of helping unpaid caregiving, which, as I say, is where most long-term care is.
Thanks, Ramon. Malcolm.
I actually think Nina's hand was up first.
So sorry. Go ahead, Nina.
Yeah, it kind of blends. Both of you made really important points. To take a phrase from an old baseball movie, if you build it, they will come. So if you build it, people not only will come, they need to have a place to go to. And I know Sarah's going to come on and talk about some of the work CDA is doing, but without a fulsome, easily accessible, user-friendly, statewide, meaningful, no wrong door system that folks, whether they're in Los Angeles or up in Trinity County, Del Norte, can get the suite of services they need. And so we know all that needs to be built in. And also regarding workforce, I'll just say personally, we're experiencing in my own household with my husband at 71, still working 4 nights a week because they cannot find substitutes for him to do the home health care that he does for a severely disabled man. If we don't find solutions to our workforce, we're going to be in trouble. And I know that we're testing models, scaling up programs in California, but somehow we have to make this field more appealing. And unfortunately, the pandemic actually drove many people away from the healthcare and allied fields. So just pretty much agreeing with what's already been said.
Thanks, Nina. Malcolm.
Yeah, I think a couple of things that in appreciation for the points that Ramon just lifted up and that Nina lifted up, and also what Nina dropped into the chat. But I also I'm thinking about things that need to be taken into consideration. I wanted to go back to a question that was lifted up in the chat by Amanda Ream, a question regarding the Medicaid asset test elimination and what that means, the long-term implications of that, especially for folks who are spending down and folks who are homeowners, what the implications are for that as we test out a model where folks don't have to worry about losing their homes as we build out a benefit, and that really would create accessibility for all, or universal access for all. And my second point, I forgot, so I will circle back to it.
Okay, you can let us know. Dan, I wanted to jump to you to see if there's anything that you'd like to raise up as something you're excited about in the recommendations, or something else that you feel is missing to the conversation.
Thank you, Emma. Hi, everyone. I'm Dan Oakenfuss. I'm a public policy manager for the California Foundation for Independent Living Centers, or CFILC. And we represent 25 independent living centers across the state in California. We're a statewide disability rights organization, and we provide a lot of the political leadership for the ILCs in California, which are run by and for disabled people with the purpose of supporting consumers with all types of disabilities of all ages, and maintaining and becoming independent community resources and assistance they may need. We've about serving over 150,000 individuals across the state. That said, long-term care is one of the most important benefits that we've been seeking since the very beginning of our organization. And we've been involved in a number of coalitions. I'm a board member here on the Collaborative for Long-Term Service and Supports. But one thing that always strikes out is that, a lot of our members they really try, they try to apply for long-term care insurance. They try to do, the steps they can do, but we just don't qualify to begin with. We're turned down as soon as they see an inkling of our medical history. So looking at a public benefit has been part of our priority for over the time we've been with CADA, and since the task force has been up. And I like a lot of the things we see here, and we're very concerned with funding mechanisms that have been suggested. And because a lot of us don't have full-time jobs, a lot of us are on disability and such, and they can't rely on what they've already paid into the system. So we really need to find a way to spread out the cost for everyone to participate and to get the service we need. A lot of them can be the services that our members are needing are personal care like bathing and dressing, toileting, complex care like for medications, and also help with housekeeping, transportation. A lot of us can't get around on a car, so there's a laundry list of things that we need that we just can't get in any kind of insurance or in any kind of current benefit structure. So really appreciate the opportunity we've had to participate in the task force public comments over the last couple of years. Thank you.
Thank you, Dan. So I am what you're saying, going back to the funding mechanisms and the payroll tax, making me think, as I think we've already heard today, we've heard about the Washington State Washington Cares Fund, Washington being the first state in the nation to pass legislation creating a public long-term care insurance program back in 2019. And that's a program that is based on a similar payroll tax. But they've experienced a number of challenges that led them to delay implementation by about 1.5 years. And so I'd like to pose to the group, anyone who wants to chime in, what are some of the lessons, good or bad, that California should be learning from Washington being a few steps ahead of us in this process? I think we've heard some concerns about the payroll tax, but what are the other things we should be thinking about?
If I could, careful measured design of opt-outs. That's what got Washington. Ramon knows this even better than me, so he's going to talk about it. But there were so many populations in Washington, aside from the issues with not providing really clear guidance on what an eligible long-term care insurance policy should look like, which meant it could be gamed. Hundreds of thousands of people opted out. There was also issue with out-of-state workers, military spouses, near retirees. Ramon, you can add to the list. There were so ARP has been deeply engaged in Washington. So I've gotten the laundry list, and I know that some cleanup legislation was passed last year and signed by Governor Inslee, and I believe they kick it off. I think they delayed it until next year, so it's not gone. They just had to delay it. But Ramon, talk away, and I'll be quiet.
Well, yeah, on the opt-out, that turned out, I think, to be a catastrophe. What happened was something like 500,000 people opted out in the state of Washington. If you multiply that number by, the factor that California is larger than the state of Washington, then we're talking millions of people opting out. And that would be at the, behest of the private insurance companies, which would be cream skimming the population. The people they'd be pulling out would be the people least likely to need long-term care, so that you'd be skewing the population left in the public system towards people more likely to need it and more expensive, and creating an actuarial problem that probably Dustin could comment on. That was the main thing. And you know, I had a relative up there. She was approached by her car insurance salesman to opt out. I mean, it was just a gold rush up there. I heard there were sandwich signs out on the streets in Seattle. You know, get out of paying a tax. Come in this door here, and we'll help you to opt out. And that's how you ended up with 500,000 probably low risk people leaving the system. So I don't think it's a good idea at all actuarially.
And I know that's something that the task force set aside as something for additional consideration, and perhaps a work group was this question about education and the education that would have to accompany implementation of any sort of program or benefit like this. So wondering if you all have thoughts on how we can start talking about this to educate people, not just about the importance of getting a program like this, you know, enacted, but then once it's enacted, how to get them prepared for a new program of this magnitude.
Was that a question there, Emma? I want to make sure that I got it.
Any thoughts on what would be necessary on sort of the education, the public education side of things to make a program like this successful?
Well, I think we need to talk to folks about, you know, what their possible needs could be and the possible financial catastrophes that await them if this system does not get adjusted, because you know, something like 20% of seniors are going to end up needing long-term care for years. It's going to put their family house equity and everything else in jeopardy. It's going to jeopardize what were going to be their children's inheritances, their grandchildren's college educations, and so forth. So I think, you know, that we need to start with outlining of what are the risks here if we don't do something to fix the problem.
Nina, I think I saw your hand next.
Well, Malcolm and I popped up at the same time, so let's have Malcolm go first this time.
Go ahead, Malcolm. It's a very nice group we have this afternoon.
Oh, thank you. Thank you, Nina. So I think in addition to what Ramon said, great response. I think there's a need to really make sure that we're working with community. And I think making sure that they're educated, making sure that we're working with long-term care stakeholders across the state, and also that we're educating, probably just as importantly, the electeds, so that they are aware of the benefit and what the different options are, and particularly and specifically making sure that groups have been organizing around this and being thoughtful about it, that though their perspectives are being lifted up into this, and that there's also, I think, community buy-in to an understanding of the model and support for the options that that in particular the CADA and the LTSS Grassroots Coalition, which we have members of here, have really been lifting up. And also that we're also being thoughtful about the impacts of this with labor and IHSS. And so really making sure that we're thinking about all of those pieces and that we're engaging around those. So I hope I responded.
Thank you.
And if I can, education needs to start before, not upon enactment. People need to hear things 28 times for it to sink in. So I'm just putting that out there. We can't just start at the time that we're, say, running the bill. I know that all of us have been talking to legislators, but it feels like every time you go to them, it's like new information. So they're really, and plus we have 36 new legislators, but we have to keep, you know, getting the word out to our constituents about the cost and the fact that no, your Medicare is going to be limited and it's likely you may not qualify for Medi-Cal. So then what are you going to do? So I just want to offer those 2 cents.
Malcolm, did you put your hand back up there?
Yeah, and then I pulled it down, but I just wanted to lift up the, and I'm going to jump in anyway. One of the points that Ramon just dropped into the chat around about the disproportionate impact of harm on communities of color. I want to say that harm is probably already happening. As I mentioned, one of the quotes, one of the statistics coming out of the Department of Aging's Master Plan for Aging. And just like really thinking about that. And as we look at that, making sure that we're educating also those communities. So we're engaging with local communities and making sure that we have buy-in and alignment with communities who have to make sure that generational systemic harm doesn't continue, and that we're thinking about the potential impacts on communities of color, but on women of color in particular, and families of color. So.
Thank you. Thanks, Malcolm, for uplifting those points. I think your reference to the master plan on aging is a nice segue to say welcome to Sarah Steenhausen and thank her for joining us. And Sarah, I know that CDA has its own work stream related to LTSS financing that's going on in addition and separate to this task force work with the feasibility study that we've been talking about. So maybe I can hand the floor to you to talk a little bit more about that funding and what we can expect to see from CDA there.
Great, thank you so much. And then I love hearing this conversation. It's so rich and so important to be considering all these elements, particularly the last discussion on education and outreach. Is one thing that I think we're constantly.
Sarah, I'm not sure. We're having you're a little garbled. We're not hearing you very well.
Okay, hold on. Let me see if I can fix this. Does this help? Is this better?
I think we're still not getting it. It's still not coming through very well.
So weird. Okay, hold on. Okay, look up now. Hello. Still garbled. Maybe I should try and just log right back in.
Yeah, maybe give that a try, and we'll turn back to you when you come back.
Yeah, I'll come right back. Hold on. Okay. Another question. I'll be right back.
Great. So maybe while we're waiting for Sarah to come back, are there other policy options or other things that we should be talking about or considering for developing an LTSS benefit or meeting some of these long-term care needs while we're working on a program like the one being considered by the task force? Oh, seeing Sarah back. Sorry, Sarah, try again.
Sarah, like you have cookie crumbles in your microphone. I'm wondering if you might just want to dial in. There's that little arrow next to the microphone button. You can switch to phone audio. That might be the best way. And Malcolm, I just want to highlight, I know that you have to jump, but if you have any final thoughts, this might be a good time. And when you need to go, you just go.
I just wanted to add a couple of, can I just jump in really quickly, Maria, if that's okay?
Please do.
So apologies, I'm a full-time family caregiver for my grandmother who's 93, and I just got an alert that her AC just went out, and we're in the middle of a heat wave. So I need to go and run over to her place really quickly. And these are those struggles that family caregivers have, right? But I also wanted to lift up points regarding pieces for us to take into consideration, especially uncovered complementary and alternative health services, and particularly housing related services and supports as we think about this and what the potential model could cover. And especially like thinking about, California as self-directed support services model, and just including several of those services and being thoughtful about that. So in addition to the cash and counsel model that Ramon lifted up. So apologies and appreciation for being here today.
Thank you for joining us, Malcolm. Let's see, Ramon, I see you have your hand up. Sarah, are you dialed in? Do you want to give it another shot?
I'm testing now. Can you hear me?
Oh, much better.
Better.
Okay, great. I'll let Ramon go and then we can switch however you want.
Well, I just want to underline what Malcolm just said, that, you know, there's an expense that any insurance list of things to pay for, run over to your grandmother's house and fix the AC, is not going to be on there. And that's why you need some sort of a cash model, because there's just 1,001 things like we just heard about that can only be reimbursed and are essential. That's it. I would want to hear what you have to say, Sarah.
Thanks, Ramon. Okay, Sarah, go ahead.
Well, thank you all for this discussion. I wish I could have been here the whole time, but I really do think that underscoring the importance of, you know, public outreach and education is so critical, because I think part of what happens is people don't even understand what long-term services and supports, long-term care is. We already have a big challenge in terms of helping people understand how to access their own healthcare benefits. You can imagine where this falls within that whole line of discussion. But I do want to say that in terms of the master plan for aging and our efforts at the state level, this is certainly, we see it as one of the highest priorities in terms of a problem to address in order to move forward and meet the needs of our older adult population, people with disabilities, and family caregivers. And particularly, as has been mentioned, it really impacts communities of color disproportionately. So we need to double down and find a solution and move forward with it. As you can probably imagine, the state does not have an official position on the work that Oliver Wyman and the Long-Term Care Insurance Task Force has undertaken. We're really appreciative of all of the work that's been put into it and are certainly monitoring it very closely and working with them on any information that we can provide to be helpful. Right now, what we're doing, you know, there's an initiative an initiative within the master plan for aging focused on LTSS financing. And specifically, it calls on the department and the state to continue to evaluate options for the development of a universal LTSS benefit. And as Emma noted, this entails, we were very fortunate to get an investment through the legislature in the budget last year of $5 million over the next, $4 million over the next 3 years to develop research, data collection, and analyses for what the state needs to better understand in order to address this issue of LTSS financing. So it's our intention not to duplicate the work that's been going on by our colleagues at the Long-Term Care Insurance Task Force, but to build off it and to kind of identify these areas where we might need more information. We are going to engage on a very comprehensive stakeholder campaign as part of it. We're meeting internally right now to start thinking through how to roll that out, but we will be taking recommendations as we have currently from CADA and others about what are some thoughts on what needs to be done. I will say that we are not limiting our efforts to additional actuarial analyses in general. We have broad authority to be able to look broadly at what research and data collection is needed. So for example, as a consideration, we might need to better understand where the population is. Maybe we need to talk to older adults, talk to people with disabilities, talk to caregivers to understand what their needs are and how to communicate these issues. That's just one example, right, in identifying the needs. And then there might be a series of other efforts as well. But it's our hope, again, to work closely with stakeholders in identifying the pathways forward for this effort. And then we will certainly be sure to follow up and do the outreach needed to engage people in this process. So happy to answer any questions, but thank you for inviting me to be here today.
Thanks, Sarah. I think I'll let Dan, Nina, Ramon, feel free to put your hand up if you have any reactions or comments to what Sarah's just laid out. But Sarah, I think, you know, you're talking, oh, go ahead, Ramon.
Well, I mean, Sarah knows better than I do, but what the legislature said they wanted is, it was in recognition of the fact that we've already, started a discussion of how to provide benefits for people that are currently working and who can come in through a payroll system. The problem with that is, of course, as I've already said, there's a whole lot of people that aren't in that system who've already retired, or people with disabilities and can't have regular jobs like that. So the new appropriation, the one that Sarah Steedhausen is talking about would look to understand how to address the long-term services and support needs of that population that doesn't fit in the model of private, payroll system, which I think is great, wonderful.
Dan,
And
did
I
you
want to
like
echo, yeah, and I want to echo that too. Exactly, many of our members qualify for current Medi-Cal funded long-term care programs like LTSS, but they also don't have the savings to pay for it out of pocket. So there's that threshold where you have to spend down or remove all your assets just to qualify for the necessary programs that are in Medi-Cal. But that's kind of counterintuitive for a lot of our consumers, and it's also that's a hit on the economy when everyone you're trying to get to that base level. At the same time, what can we do to grow people up to qualify and not qualify, but also to have more savings power to pay into such LTSS.
Yeah, absolutely.
Thanks, Dan. Sarah, I'm really appreciative of what you said about this LTSS question being one of the real priorities and the initiatives in the master plan. But I think as we're thinking about the broader master plan, and I've heard you say that we can't finance a broken system. And I think that's a really important perspective of the idea of financing being necessary, but not sufficient. So I wonder if you can speak a little bit, and then our other panelists can chime in on what are some of the other things that we should be working on parallel tracks as we tackle the affordability challenge.
You are 100% right, and I thank you for elevating that. I mean, the way we look at it is from the LTSS perspective, and I know I outlined this yesterday in the other conversation with the California Collaborative, but it's kind of 4 buckets that we're looking at. And this all started with the LTSS subcommittee and the way that they categorize the big theme issues that are impacting our system. First being LTSS financing, which we just covered. As you said, Emma, you can't finance a broken system. So the second component to system change is really looking at our infrastructure. Do we actually have programs and services available across the state to meet the needs? Even if we have a financing mechanism, you don't necessarily have a way to access services if they aren't in your community. So we're doubling down on our commitment to do we've launched the Home and Community-Based Services statewide gap analysis and roadmap effort in partnership with Department of Healthcare Services. And over the next few years, we will produce the gap analysis, and then after that, build out the roadmap for what the state's plan is on building out the infrastructure and capacity in the system. The third issue beyond financing and infrastructure is that of navigation. So even if we were to fully fund the system and we had services available in every community, so many people don't even know those services are available or how to access them or where to go. It's not like people are walking around thinking about long-term care every day, right? So we really need to focus on better streamlining access to information and supports. And our goal is through the development of building out our ADRC, Aging and Disability Resource Connection program as part of it on a statewide basis. But it's also about kind of having the state level infrastructure of the terminology is a no wrong door system. And what that means is that no matter where you're coming from, what program you're needing support from, you have a way to access information very quickly. And that could be through either a statewide web portal that is available that recognizes the whole range of services beyond HHS, but also looking at, housing, transportation, all the supports that people need when they're thinking about community living, and quality of care information. Longtermcarecompare.org. That's been a really great tool. How can we bring that into a future web portal so that people have at their fingertips the information they need to make informed decisions? Second to that is building out the infrastructure for a contact center. We know that our area agency and Aging and Disability Resource Connection partners are doing great work in providing information and assistance to people that come through that system. But what's the step before that? I know a lot of people aren't even aware of what these programs are. So if we have a very well-known state-level contact center where you can actually talk to somebody at any time of the day and then get a warm handoff to the partners at the local level. These are concepts that are at the very early stages of conceptual development, but we really hope that by 2030 we can have it in place. So happy to have follow-up conversations on that as well. And then finally, in addition to those three issues of financing, infrastructure, and navigation, we have the issue of workforce, which is equally as important. We could address all these other challenges, and if we don't have the workforce we need, and we don't support them and pay them what they deserve, we aren't going to have a system. So, there's several efforts underway to both build the pipeline from direct care workers through the clinical workforce, and then second, to include the training opportunities. By no way have we solved these challenges yet, but I think we need to continue to double down on all of them so that we can kind of system-wide address these issues. And I think what I want to underscore is that what ties all of this together is both data and culturally responsive services. So we need to understand the needs of the system, and that's where data comes in, and the needs of the people. And then second, we need to ensure access through culturally responsive approaches, whether it's language access or, ensuring accessibility in all programs and services. That's something that we also need to think through. So that is the thinking, but I see that Dan has another comment or question.
Yeah, but let the panelists
Sorry.
chime in on this question, and then we'll go to audience Q&A after that. So Dan, go ahead.
Just a quick shout out to the department's ADRC program. We are half of that. We are the disability half of the ADRC, and with our partnership with the county area agencies on aging, and then the living centers that are in these counties as well. It's that true, dream of a no wrong door system where our consumers, whether you're going to the C4A or going to the ILC, they can know there's a one stop where they can finally get those connections made to the services they need. And so that is one of the reasons why we've been hoping to get a little bump in the budget there to keep as more and more of our centers come emerging into the ADRC program. We need that extra funding just to keep the program solvent and more incentives for others to join. So thanks so much.
Thanks, Dan. Ramon?
Yeah, the no wrong door thing, I think, is going to be critical for standing up our system, making it work. So much of California right now doesn't have anywhere to call to get these kinds of questions answered, and we need a statewide system that answers those questions. So beyond that, let me shut off my cell phone here. Sorry. And then also, we need to think about things like family leave, housing costs, and other kinds of issues that factor into the quality of long-term care. Because again, as 2/3 of the system is outside of the paid, long-term care world, it comes down to family members, loved ones who are providing the care, and then who have a whole range of auxiliary issues that, if they do or don't work well, affect how the system turns out. So, family leave is a big deal, because if people could get off work to care for their loved ones, then things go a whole lot better. And housing cost, cuts across this issue as well. So I hope that as part of the, long-term study of what's needed here, we also pick up these kinds of factors.
Thanks, Ramon. So I know that we have some great audience questions that have come in already, and encourage them to keep putting your questions into chat. We appreciate Dustin for sticking around, because I know there are some specific questions that came up, making some clarifications on some of the recommendations. So maybe we'll start with those. That's okay, Dustin. So first question is there any more detail available at this time on how we define and determine severe cognitive impairment as we're thinking about the eligibility criteria for the program?
Yeah, that's a good question. We didn't go into the full layer of detail in that decision with the task force. So that's still to be determined. That said, the recommendation from the task force is to look at an eligibility definition that's in compliance with like tax qualification standards under private insurance. So it would be that severe cognitive impairment, but that's like the details of that may not be fully defined at this point. So my short answer is that's an open question.
Okay, thanks for clarifying. And then could you speak a little bit more about the benefit limits, the lifetime limits or annual limits, and how eligibility for the program would work when someone uses up all of their benefits?
Yeah, so it would be lifetime limits and further subdivided into, I think the current recommendation from the task force is a monthly limit. So you would divide, depending on the design, you would divide the amount by 12 if it's 1 year, 18 if it's a year and a half, or 24 if it's 2 years. So it varies depending on design. That amount would increase each year as a function of a consumer price index. So it's not fixed, but it would be a one and done, a one-time limitation. Once you've used the entire 36,000 or 144,000 or somewhere in between, your benefits will have been drawn down and no longer available.
And maybe you could just clarify. I think earlier you were giving a hypothetical scenario using 2025 as an implementation year and full benefits then being available until not until 2045. So we have a question about clarifying that full benefits wouldn't be available for anyone until 2045. Maybe you could just reiterate the timeline of the program, what you expect.
I want to be careful not to specify any specific year. There's no, this program is still a recommendation. Nothing has been enacted. So these are all hypothetical years, but let's go with that scenario. If a program were to come into effect in 2025, there's that intergenerational consideration, which basically the task force wanted to be mindful that someone, in their younger years, say 18 or who joins the program when it launches, would be contributing potentially 40, 50 years, a very long time, relative to individuals who might contribute less. And so in recognition of that, and the cost of a program, that the task force felt that it was appropriate to grade up or increase benefits following the program's launch. So, hypothetically, if it were to kick in 2025, it would grade up 5% each year. So in 10 years, 50% of the benefits would be available. And in 20 years, 100% of the benefits would be available for the rest of time that the program's in effect. And so recognizing that there's also a minimum number of years you would need to contribute, the vesting requirement that's either 5 years or 10 years. So that means after that 5 or 10 years, there is a window where if someone were to use their benefits, it would be a little lower for a few years until the program is fully rolled out.
Thank you for sharing that additional context and clarification, Dustin. Appreciate it. So maybe we'll wrap up by pulling us back from out of the weeds and a little bit further up into the big picture. We had an audience question asking, as we're looking at a statewide LTSS insurance program, how do we think about and consider the cost savings of preventing costlier care? So, adult day services, for example, could prevent ER visits, hospitalizations, nursing home placement, and a lifetime benefit of $36,000 on preventive services might not be reflective of the cost savings that can be accomplished. So, any thoughts the panel on how this could be accomplished? How to best this?
Was that question for me or for the broader group?
I'll put that to the broader group.
Yeah, maybe I'll just make one comment. So I know this, the idea of preventative benefits, the idea of offering lower cost benefits to mitigate, fiscal impact on Medicaid, or mitigate an individual spending down their own assets. That was something that the task force discussed quite a bit. And so in recognition of that, all of the program designs include a promotion for or promote the use of preventative benefits. And the types of preventative benefits have not fully been defined. But even in the least costly design number one, there would be some form of that to ideally reduce some of the more expensive types of care that you mentioned, Emma.
Thanks for that perspective, Dustin. Any other? Yeah, Ramon, go ahead.
Yeah, well, and prevention can be thought of not just as, giving people tests and things like that. Prevention applies at the whole spectrum of care. So secondary prevention, tertiary prevention, if people get the right kind of care, even if they're very ill already, to keep them from getting worse and developing complications that then generate new kinds of costs that were avoidable, there's a whole range of ways that proper long-term services and supports could save money. And I think that's critical to factor that into any long-term calculation. I know that's not quite what insurance actuaries do, but folks who are looking at the broader picture should attempt to factor in what would be the savings of properly providing care for people in the first place and keeping them out of hospitals and long-term care facilities that they could have avoided had they gotten the right care.
Thanks, Ramon. I think we're getting to the end of our time here. And so before I pass it back to Maria to wrap up, any closing words from any other panelists that they'd like to leave our audience with? I think we've said the important things. Oh, Dan.
Sorry, I realized the problem of having a hand on a yellow background doesn't really work very well. But yeah, I am talking about the last question, I think, or last comment, I think it was from Nina about detailed legislation. And a lot of it's going to be a huge selling challenge for us to the legislators, is, the need for it and also educating them. It's going to be more than just reading the task force report. It's going to be, engaging all our consumers and our grassroots to, fight for this and, cry out for the need for it.
It's a great note to end us on. Thank you, Dan, and thank you to all of our panelists for the conversation and for your insights. It was really engaging. We appreciate it. Maria, back to you.
Yeah, thank you so much. I just have a quick little spiel. I want to thank all of our panelists for joining us today. Emma, what a wonderful moderator you have been. It's been such a pleasure to hear from all of you. I've been sitting back and writing detailed notes about some of the comments that I've heard. Of course, the work lies ahead, as it always does. There's always more to do. And I know, Dustin, based on what I heard about your timeline, is that we are expecting the actuarial study to be available by the end of the year, sometime in the fall. So I know that we're all going to keep our eyes and our ears peeled and hopefully bug you again at the end of summer or the fall to see if we can bring you in and help us to understand what that actuarial study looks like. So thank you all. Just again, want to share a caveat that this is recorded, and so we'll share that out along with the materials, and appreciate any feedback you have and hope you enjoy the rest of your week. Thank you so much. Bye, everybody.